professionals who practice in a compassionate way and environments that clearly create a caring and compassionate environment lead to patients doing better, to families being more engaged, to better outcomes overall in healthcare.
What we know from research is that when we bring kindness and caring and compassion to our patients, we actually elicit a very powerful physical response. Genes are turned on, new proteins are synthesized, healing is enhanced, the immune system is bolstered, dangerous stress responses are dampened down, and patients recover quicker and get better outcomes. What I do is I build trust and rapport with every single patient, and I find out what's most important to them, what their concerns are. Then I bring my knowledge, skills and resources in the service of the patient's life. My patient sets the agenda for care. I'm relating to patients in that way. That's the thing that builds their trust, their rapport, that elicits the healing response and gets much better outcomes for your patients.
Some patients recover because they believe in their doctors. In order for a patient to trust and believe the physician is a condition full of empathy and unconditional positive regard.
So patient engagement, the idea behind it is that in working with patients, working with patient advisors, that we can design health systems that are more compassionate, more patient-centered. This is a very strong social innovation that we're talking about. And in using the research to be able to talk about these kind of complexities, then we can have better conversations with the practitioners, with the patients, with the policymakers who are making decisions that make patient engagement possible.
Every time I see a patient, I really try to focus on this is another human being who has a problem.
Unless I have compassion to my patients, I can't treat them. And for me, compassion means putting myself in the shoes of my patients and understand them and help them to get out of their problem.
How am I bringing caring and compassion to healthcare? Obviously, it's how I relate to my patients. And first and foremost, it is about listening, careful listening to the patient. As an educator, I know how role modeling is important. So when I interact with patients in front of students and residents, I do my best to be a good doctor who is caring and compassionate.
Compassionate care is about using the best evidence in empathy and altruism research to bring about better patient outcomes.
Our study is a systematic review of the factors in the formal, informal, and hidden curricular that may foster or inhibit the development of empathy in medical students and doctors.
In our medical faculty, we developed a 60-hour experiential empathy training called Empathize with Me Doctor. The Empathize with Me Doctor project is based on the principles of the person-centered approach and seeks to embrace not only the physical symptoms of the disease, but all the emotional and psychosocial aspects as well.
I learned how to listen, observe, and pay attention not only to our patients' symptoms, but also to their fears and concerns without judging them.
Empathizing can help me reach the right diagnosis, but also approach the patient with dignity and respect.
Over the last several years, with the increased pressure on doctors to become more quote-unquote efficient, that is, to see more patients in less time, to get patients out of the hospital faster, there is a much greater emphasis on cure than there is on care. And of course, without addressing these other aspects of the disease experience, it's very difficult to offer a treatment plan which the patient will embrace and which the patient is more likely to carry out.
It is about getting people to somehow really reflect, be mindful. We also use, and many schools do, what I might call out-of-body experiences. Experiences where we try and, by taking medical students through events or experiences that take them out of themselves and out of the discursive environment of the curriculum and passing assessments and impressing me. And we use, for example, devised theatre as a technique to address features of the hidden curriculum. and indeed challenges of transiting from one state of student to another or graduating. And students do wonderful things with devised theatre that really help them to really live and be in this experience of the patient, or of doctor-patient relations, or indeed of themselves in their states of transit or navigating the complexities of hidden curriculum. We also, a wonderful colleague of mine, invented a simulated diabetes experience where students for a week take on the role of being a type 1 diabetic. They go through and have to use a diabetic diet. They have to inject themselves twice a day. They have to take blood tests 4 times a day, and they come out of that quite moved. And certainly, I think, potentially empathetic, if not compassionate, about people with type 1 diabetes. It is using the imagination like that and placing students in situations of genuine, perhaps discomfort, that might help them to begin to empathize, given their own relative lack of experience.
If we don't value our healthcare workers sufficiently to try and understand how we can transform their training and ethos towards compassionate care, we may end up with a healthcare system that has the hardware, but sorely lacking the heartware.
We need to create a space in all of our institutions that embraces, welcomes the discussion about caring and compassion. There are many other imperatives: efficiency, cost savings, evidence-based practice, safety. These are all very, very important, but we have to be sure that sitting at the table with these other concerns is a space and a place for us to ask, are we really developing caring, compassionate care in this hospital, clinic, medical school, nursing training program, continuing education program, everywhere? So the simple answer is creating a space to be sure that that is included in our consideration of what good health care is.